Good evening, doctors. Am I audible, doctors? Please say yes if I'm audible. I hope I'm audible. Yeah, please answer yes if I'm audible. Yeah, good evening. Here I am Dr. Afshan Banu, and once again with a very good webinar topic uh, regarding composite restorations. So, like posterior composite restoration has already been taken twice through our everyday essentials free webinars, but new people they keep on joining, and it's a very important topic which is bread and butter of us. Every day we do composite restoration. So on our poll we got it like the posterior sorry, the composite restoration was the major topic which everyone voted for, and also regarding the irrigation protocols and everything. So we will be covering one by one whatever the majority had asked for. So coming to today's topic, so today I have actually gone into few very basic tips and tricks here and there where you can add it. So everyone is doing composite restoration. Everyone is in everyday practice. It's like we cannot avoid composite. It's like people come to us asking for composite tooth colored restorations, and they specifically ask if you are having composite resin. So that's how it has become very familiar among the every people, not only in dentistry, among every common people as well. So we can never avoid composite in our everyday practice. So we need to know something. So why people are afraid of composite? So many of them are afraid to do a composite because of like reasons like patients come back with complaints of sensitivity, or the restoration dislodges, or some kind of problem happens whenever we do a composite restoration. Yeah. So we need to identify why those mistakes happen, and what can we add throughout our procedure, like one by one, starting from the tooth preparation, then going for the etching, bonding, and doing a restoration, and to the polishing protocols. So what we need to do, what we need to add throughout the techniques, here and there some corrections, so that we can have a very good predictable composite restoration. So that is going to be the outline today. So let me introduce myself once again for anyone who is new here. So I am Dr. Afshan Banu. I have been practicing in Madurai and Chennai. I am an endodontist, aesthetic dentist, and also a microendodontist recently. Okay, so recently I have actually started using microscope as well in my practice. So like that's about me, and let's get dive into the topic. So, if you have any questions throughout the session, feel free to shoot your questions in the chat box, and I will be answering all the questions at the end of the session. So, we will be having all the theory part, like what all I will be telling you about what you can add throughout the composite restoration procedure, and after that, we will have a 10 minutes break so that I can set up for the live demonstration, which is exclusive for this webinar. So I will be showing you a demonstration on a class one, like how you can do a selective edge and what steps you need to do on a model. And that is the brief about what we are going to do today. So starting with a composite restoration. Okay. So whenever we do a wrong restoration, so let's say we have done some mistake through when we are doing a composite restoration. Let's say I have done some mistake in the diagnosis, or while doing the tooth preparation, or while etching, or some mistake I have done. So what happens is the restoration either dislodges, or the patient has some complaint on sensitivity, the patient comes back to me. So now when the patient comes back to me, the first thing is the patient will lose trust on me, right? The patient will actually lose trust on me, even though I can tell the patient, this one, the restoration has failed, we can go for a metal inlay, we can go for a ceramic inlay, or we can even go for RCT crown. We can tell them anything, but I was not right the first time. The procedure what I did failed. So the chances of patient trusting me is quite, questionable. right? So what I will be doing is I will be actually repeating the restoration once again, or I will be compensating them with something like I will just subtract the restoration cost from it. Whatever I will do, either I repeat the restoration or I subtract the restoration cost or whatever it might be. Ultimately, I'm going to lose money, and ultimately, I'm going to lose the trust of the patient, right? So it's always important whenever we are doing a composite restoration, it's very, very important that you have to be right the first time. So sometimes in a composite restoration, if a mistake has been done already, so for example, some other dentist has done a restoration. Okay, so some other dentist has done a composite restoration, and the patient comes to me with a complaint of either dislodgement or the complaint of sensitivity or something like that. Okay, so now I take up the case. So if you ask me what is the success rate of my composite restoration, in fact, I am very successful. Like I have done almost many composite restorations and nothing have failed if I have done it the first time. Okay. But when I'm doing it the second time, that is already another dentist has done and it is failed, and I'm going to do it the second time. And my chances of success rate is going to reduce a little bit. Okay. So success rate will be around 80%. Why? Because the damage has already occurred. Okay. So already there is a damage to the dent and already there is a damage to the pulp. So even if I place a restoration very perfectly the second time, my success rate is quite low when I'm repeating a composite restoration. So that is a very big thing which many of the practitioners they don't know. Okay, so that is the reason why when we repeat the composite restoration, we are very confident. We tell the patient, yeah, if I do the composite restoration, it is going to be very successful. But when I repeat the composite restoration, again, the patient is going to have the same complaint, even if I have done it everything perfectly. So that is a very major problem in composite restoration. If you're doing it the first time itself, it has to be correct. Okay, so there is no second time in composite restoration. As you're going to repeat the composite restorations, the success rate is going to reduce, even if you're going to do a perfect restoration the second time, even with a rubber dam or anything, the success rate is going to reduce. Okay, so you have to be it is very important that you have to be right the first time itself. And whenever you get a case with failed composite restoration in your clinic, always tell the patient. Okay, so always tell the patient about the risks and then start the case. And even like sometimes you might succeed, sometimes again if you fail, or if there is a dislodgement of the restoration which you have kept also, you can go proceed with metal inlays or some other options rather than repeating a composite restoration. Okay, so this is very important. So first time itself you have to be right so that you get a very good reputation and you don't lose money as well. Okay, so coming to why, what are the major complaints with which the patient will come to your clinic? So the first major complaint after doing a composite restoration, a patient will come back to you with sensitivity. That is going to be your first problem. The second thing is going to be a dislodgement or a broken restoration. So these three things happen because of these, like both these things, the sensitivity and the dislodgement or a broken restoration happens because of this. Okay, so either because of a polymerization shrinkage or because of a marginal seal loss, which happens because of adhesion bond strength. So whenever the strength of bonding between your composite restoration and the tooth is going to be very good, there won't be any marginal gaps. There won't The marginal seal is going to be perfect, and there won't be any seepage of fluids because of which sensitivity will happen, or there won't be any dislodgement of the restoration when the bond strength is going to be high. The same way, whenever there is going to be very less polymerization shrinkage. So let me give a brief about what is polymerization shrinkage. So our composite material is actually similar to our self-cure, which we use in prosto. Okay, so it's quite familiar, not very same, but quite familiar to it. So what it happens is there are many monomers. Okay, so there are many individual molecules are present which will actually combine together to form a single unit. So there are many separate units, monomers, on the incident of light or a chemical activation or a heat activation. What they do is they come together and form a single unit. Okay, so that's how your composite mechanism of setting happens. So now what happens during this polymerization procedure is, since these individual molecules come together, there are spaces. in between these molecules which are left there. Okay. So because of which there are gaps created in between the teeth and the restoration. Okay. So because of complete polymerization, the monomers come closer to each other, gaps are created, and those gaps form they form marginal gaps in between the restoration and the teeth. So you have to reduce the polymerization shrinkage. That is, you have to completely polymerize a layer of composite. Then only we have to place a second layer of composite, so that after the polymerization has happened, whatever gap is there, it should be filled with a fresh composite. Okay. So there shouldn't be any gaps in between the restoration and the teeth. That is our first goal. The second goal is to have a very good strength in between the restoration and the tooth. Okay. So whenever we are going to reduce the polymerization shrinkage, or whenever we are going to completely seal the restoration, okay, there won't be any marginal gap. And the second thing is, whenever the bonding between the tooth and the restoration is going to be very good, there won't be any marginal gaps. So whenever we are going to prevent these two things, the polymerization shrinkage, and when we are going to increase the bond strength, automatically we will have a proper marginal seal, and our restoration is going to be a successful one. Okay. So our goal in general is going to be oriented towards these. Okay. So we are going to do techniques. We are going to implement few techniques into our restorative procedure, which will actually decrease the polymerization shrinkage and increase the adhesion bond strength. So starting with a tooth preparation. So just tell me in the chat box, so which is the good burr you have to use in case of if you're going to do a cavity preparation for a composite, you should use a diamond burr or a carbide burr. Which is the best burr to use? Carbide, diamond, yeah, any other answers? Diamond, 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 stainless steel. Very good. Then carbide. Okay. So I will be telling you some base about the diamond and carbide burrs here. So if you would have seen in your books, okay, your final year books, you would have come across these slides. Smear layer formation with diamond burr and a carbide burr. So this is a surface cut by a carbide burr. This is a surface cut by a diamond burr. So carbide burr, if you can see, the surface is the smear layer is very less. In case of your diamond burr, the smear layer is more. Okay. So why? Because your carbide burrs will actually cut the tooth structure. It will cut it like how we chop the vegetables off. It will chop the tooth structure and it will discard it. While your diamond burr is actually abrading. Okay. It will actually, it's just like how you're, doing some wall works and all, right? The putty works and all. So you're just going to rub the diamond particles on the tooth structure, and it is going to rub and make it into a powder and remove it off. Okay. So since this diamond burr is going to rub the surface, make it into a powder and remove, there is going to be more smear layer. Okay. While when you're going to use a carbide burr, since it is going to chop the tooth structure and cut it off, there is going to be very less smear layer. So whenever you're going to have a less smear layer, the bonding of the composite restoration is going to increase. Okay. So the purpose of etching, the main purpose why we etch the enamel surface or why we etch the dentinal surface is partly to remove the smear layer, right? So whenever we are going to remove the smear layer off, the bonding is going to be better. So now, can you tell me which will be better? So according to the theory, we are going to have a carbide burr is going to be the better option when we are going to do a composite restoration. Yeah, right? So mistakes start here. So the major burr which we use in our clinic is always a diamond burr. We never use carbide burr, right? So you need to switch to a carbide burr. So that is the inference out of here. So whenever you're going to do a composite restoration, especially when you're doing it in a posterior, always choose carbide burr. Okay. Carbide burr, similar to your 245 burr, which you were using it for amalgam restorations in your college. The same burr, you can use it here as well. Or you can use a 247 burr, this one. Yeah. So to remove the caries, you can use a round carbide burr. For the walls, you can use a 247 or a 245 burr, which you were using for amalgam. And also for the floors, you can use a inverted conical carbide burr. Okay. So to prepare the major cavity, you have to use a carbide burr to remove the caries, to prepare the walls, to prepare the floor. Now there is a downside in using a carbide burr. That is, your carbide burr is going to cut the tooth structure. Okay. So you have to be very careful because you might overcut. Okay, so unlike your diamond burr, it is not going to scratch and make it into a powder and remove the tooth structure. It is going to chop off the tooth structure. So you should be very careful when you're using a carbide burr. You might tend to prepare more. Okay, so you have to be very careful. And always the major cavity preparation, removal of caries and everything should happen with a carbide burr. But yet we cannot avoid diamond burrs. Okay, so we cannot avoid diamond burrs. I will tell you why we cannot completely avoid diamond burrs in the next slide. Okay, so we are using a diamond burr as well. We will be using a taper fissure burr or a flame shaped burr. Okay, while doing a cavity preparation for a composite restoration. But major cavity cutting, that is your caries removal, your wall preparation, your floor preparation, everything should be done with a carbide burr. You can use a 245 burr for everything, or you can use a 247 burr or any type of carbide burr, round carbide burr or inverted conical carbide burr. You get it in dental cart as well. So you can use a carbide burr for major cavity preparation. But yet we cannot avoid diamond burrs. We need to use it even though it produces more smear layer. In certain regions, we have to use a diamond burr. Especially, we will be using a taper fissure burr and a flame shaped burr. Okay, so why? Because so many of you would have noticed, you would have done a very good composite restoration. Okay, you would have done a very good composite restoration and you would have done a very good carving and then you would have done a very good polishing. After polishing, suddenly you would find a white line in between your restoration and the tooth. Now tell me, how many of you have come across this? Okay, so after doing everything properly, after polishing, just after polishing, you will find a white line in between the restoration and the tooth. How many of you have come across this? Anyone out there? Just tell me, yes, I have come across. I have come across that. Especially in posteriors, because people don't give bevels in posteriors. That is the reason. Okay. So here, why this happens is because uncut enamel rods. So there are uncut enamel rods in the margins of the restoration. In the KO surface margin, there are uncut enamel rods. These uncut enamel rods, they do not bond with your composite restoration. Only cut enamel rods bond with composite restoration. That is why whenever you want to bond a composite restoration with the tooth, you know your mentor or your teachers would have told you you need to at least roughen the tooth structure. Whenever you did your anterior composite or something in your college, they would have told you you need to at least roughen the surface. Only then your composite will bond, right? Why? Because your composite will bond only with cut enamel rods. So now what happens is that whatever enamel rods are there in the cavo surface margin, they are going to be uncut. They will not bond with the composite. So what happens after you did all the polishing, it will come off. So there will be, when you're going to see a microscopic image, there will be a gap in between the restoration and the teeth in the cavo surface margin area. So that is why even if it is a posterior or anterior, irrespective of what restoration or what tooth you're doing, you need to give bevel in the margins. Okay. So in posterior, you will be using a football shaped burr. And in anterior, you will be using a taper fissure burr. So this is going to be your routine. Even for the posterior, you are going to give bevels in the margins. You need to give bevels in the margins of the cavity preparation. So bevel, you can give short bevels or long bevels. It depends on you. Whenever you're going to give long bevels, it is going to be more aesthetic. Whenever you're going to give short bevels, it's quite acceptable. Okay, so long vowels are going to be more aesthetic. So when it comes to posterior, aesthetic is not that much important, but we need complete marginal seal, right? So short vowels are acceptable. When it comes to anterior, we more prefer long vowels. Okay, so here you should give bevels even for the posteriors. The cavo surface margin should be beveled. You can orient your burr, your flame shaped burr at 30-degree angulation and just bevel all the margins. So this is where you will be using a diamond burr. Okay, so only for the bevels. Everything else you will be doing with the carbide burr, provided you need to have the control because it will cut more fast. So you have to have that control. If you are not able to do, if you're not able to control, or if you think that you will cut more too, then it's better you use a diamond burr because carbide burr tend to cut more. So always for everything else, you have to use carbide burr. Just give a bevel with a football burr in the margins of the preparation. Okay, in posterior and in anterior, you can use a taper fisher burr. So when you're going to give a bevel, automatically this white line is going to disappear. Okay, so that is the reason why you get white line, especially in anterior, in the posteriors, because we give bevels in anteriors. Everyone knows, and they will teach you in the college also. We have to give bevel for the anterior, but they don't teach that we have to give bevel for the posterior as well. So this is how you should give bevel. So with a flame-shaped burr or a football burr, you can just give a bevel so that the enamel rods which are there in the margins as well, they become cut and they bond with the composite. So you don't have any gaps and you will not find any white lines. So now starting with etching. So etching is a very important step which we literally ignore when we are doing the procedure, right? So what we do is we will just damp some etchant on the cavity preparation, leave it there for 35 seconds, wash it off and air blow it and just go for the bonding agent. So that's how I have been doing it when I didn't know these things. Okay. So even I did those mistakes, and from my mistakes, I started learning. So I want you guys to also know the importance of how etching plays a very vital role in any composite restoration. And also I was telling you about some irreversible steps, right? So my success rate will go on reducing when I repeat a composite restoration. So the major thing which reduces the success rate is when you're going to do a wrong etch. Okay, so when you're going to etch wrongly, you are going to irreversibly damage your dentin. Then so dentin will not, dentin is actually has very conditional love towards composites. Okay, so your enamel, in fact, it has a very it has unconditional love towards composite. So your enamel actually it loves composite unconditionally, no matter what you do, how much ever you etch, your enamel will actually bond with composite no matter. Okay, so you just need to roughen and you just bond the composite, it is going to bond. But your dentin has conditional love towards composite. So dentin only if you meet some conditions, if you are like favorable towards the dentin, if you do steps according to the dentin only, then it will bond with the composite. Otherwise, it is going to backfire. Okay, it will not love the composite. Cementum is totally opposite. Cementum, you can never bond composite with cementum. Some people will tell you deep marginal elevation you will do with composite and all. So I don't believe in that concept at all. Whenever I am doing deep marginal elevation, I am using resin modified GIC. Okay, I am using resin modified GIC for deep marginal elevation because I believe that cementum hates composite. Okay, it doesn't bond with composite at all. So whenever I have to bond a composite over cementum, I prefer RMGIC rather than using a composite. And then on top of it, I give in whenever there is dentin or enamel, I proceed with a composite. Okay, so this is how your composite will bond with enamel, dentin, and cementums. Why dentin is too much conditional? Because of its structure. So when we notice the dentin, its microscopic view, when we are going to cross section and see the dentin which is far away from the pulp. Okay, so let's just see the dentin which is far away from the pulp. So this is the dentin which is far away from the pulp, closer to the enamel. So if you see, the dentinal tubules are small. Okay, and the intertubular dentin, that is the dentin in between the two dentinal tubules, is more, right? While when you go closer to the pulp, okay, so dentin which is closer to the pulp, if you go and have a cross section, you will find something like your dentinal tubules are wide and your intertubular dentin is very less. Now, how does it affect the bonding? So your composite, it doesn't bond with dentinal tubules. Your composite, your bonding agent doesn't bond with peritubular dentin. It bonds with intertubular dentin. Okay. So your composite or your bonding agent, especially because we are going to apply bonding agent only here. So bonding agent will not bond with your peritubular dentin. It will not bond with your dentinal tubules. It is going to bond with your intertubular dentin. So this intertubular dentin will have something called collagen fibers. So this intertubular dentin will have collagen fibers like this. So your bonding agents are going to infiltrate into these collagen fibers and they are going to form a hybrid layer. So this is the mechanism which is going to happen there. So whenever there is less collagen fibers, the bonding is going to get compromised, right? And only when the collagen fibers are intact, a network like this, your bonding agent can infiltrate into it and it can bond properly. But if the collagen fibers collapse, what happens? Your bonding agent cannot infiltrate, it cannot catch the collagen fibers tightly, and the bonding is going to get compromised. So, when does this collagen fiber collapse? So, whenever you're going to etch too much, your collagen fibers will collapse. Once the collagen fibers has collapsed, you can never bring it back. Okay, if I have done it today, okay, even if the patient is going to go to a very experienced dentist or a very experienced aesthetic dentist who does very good composite work, even if the patient is going to go there, if the collagen fibers is once collapsed, it can never be brought back. Okay, so that is why when you're going to do a composite restoration, if it fails, again the success rate is going to reduce even if you're going to do a perfect composite restoration. Okay, so you have to be you have to be right the first time itself. You have to preserve the collagen fiber network because etching too much can collapse the collagen fibers. Okay, so you have to be very selective, okay, about how to etch which region. So there is too much of intertubular dentin in the superficial dentin, while here you have very less intertubular dentin or very less collagen fibers. So now you would have understood something. Whenever you have more intertubular dentin, you can etch a little bit for a more time. Whenever you don't have intertubular dentin, you are going to completely reduce the etch. Okay, so that is the mechanism. More intertubular dentin, more etching, less intertubular dentin, less etching. So we have come to a term called a selective etch. So your total etch doesn't work anywhere. Okay, so you have to forget the term total etch. That is just putting the etchant into the cavity preparation and washing it off, and that doesn't work now. So you have to etch your enamel separately, you have to etch your dentin separately, and in dentin itself, you have to etch the superficial dentin separately and deeper dentin separately. So you have different times of etching. That is the duration for how much time you will etch varies for your enamel, for your superficial dentin and your deeper dentin. So now coming to, we will just talk about superficial dentin in this slide. So there are many generations of bonding agents, so which I will be coming in the bonding agent part. So for now, what I prefer is generation 5, either go with generation 5 bonding agent or you can go with generation 8 bonding agent. Okay. So your generation 8, your 6, 7, 8 is going to be self-etch bonding agent. That is, they will have etchant inside the bottle itself. Etchant, primer, adhesive all together in the bottle itself. That is going to be your generation 8. Your generation 5 will have only primer and adhesive in the bottle. You have to etch separately. Okay. So you cannot use generation 5 in deeper dentin at all. Okay. So in deeper dentin, you should never etch. Why? Because it is very closer to the pulp and it is having very less intertubular dentin. So we are not going to etch separately. Whenever I am closer to the pulp, I will never put etchant in the deeper parts of the dentin. I will not be using a generation 5 bonding agent there because I can use generation 5 only if I'm using a etchant. Okay. If I'm not using etchant, I cannot use a generation 5. I have to use a generation 6, 7 or 8 because it will have some etchant inside it. We can do self-etching. So now whenever I'm having a caries like this, I'm having a cavity preparation like this, where only a superficial dentin is involved, I prefer generation 5, where only primer and adhesive is there in the bottle. I need to separately etch. So what I will do is I will do selective etch. I will etch the enamel for 20 to 30 seconds, and then I will etch the dentin for 15 to 10 seconds. And after that, I will wash it off and go for the bonding procedure. Now, how I can do it is I will first apply the etchant in the enamel, and then I will wait for 10 to 15 seconds, and then I will apply it on the dentin as well. And then after 5 to 10 seconds, I will wash it off. So this is how we will be doing it whenever we have a superficial caries. But whenever we have a deep caries, okay, so whenever the caries is like this, so whenever we have a deep caries, when closer to the pulp or pulp involved or something like that. So whenever pulp is involved, we will be giving a pulp capping material like MTA or a biodentin or something like that. And after that, what we will do is we will not etch this part of dentin that is closer to the pulp. We will not etch. What we will be using is a self-etching bonding agent, generation 6, 7, 8 self-etching bonding agent in this region. Okay, we will etch only the superficial dentin and the superficial enamel. Superficial enamel, sorry, the enamel for 15 seconds, superficial dentin for 5 seconds, wash it off. After that, we will be applying self-etch bonding agent all over, and we will proceed with the bonding protocol. Okay. Why we have reduced the etching time when we are using a self-etch bonding agent is because there is etchant inside the bonding agent. Okay, so it is going to etch, but not to a very good extent. It will etch very mildly. It will not etch too much. So that is why we are etching a little bit. We are not etching like how we did for generation 5. We are reducing the time of etching when we are using a self-etch bonding agent. And deeper part of dentin, we will completely not etch at all. We will directly use a self-etch bonding agent. Okay, so this is going to be the etching protocol which you will be following. Selective etch technique. So you will etch deeper part of dentin in a special criteria. Like you will never use any etchant on the deeper parts of the dentin that is closer to the pulp area. Superficial dentin, you will use etchant for a lower time, that is 5 to 10 seconds. And enamel, you will etch up to 20 to 35 seconds. It's up to you. You can like etch how much ever you want. Maximum, you can etch up to 35 seconds in enamel. And this is for the primary teeth as well. So primary teeth, they have more enamel, right? So because of which their etching is actually too long. Whenever it's newly erupted teeth, they will have thick layer of dentin. So depending on that, it varies a little bit. So now whenever you have a closer, that is dentin closer to the pulp or approximating pulp, you will be using a pulp capping agent. That is vital pulp therapy. You can do using a MTA or a biodentin. You will keep a layer of MTA or biodentin closer to the pulp in the floor. And after that, you will be going to a self-etch bonding agent. Okay. So dentin closer to the pulp, we should never etch. We should use only self-etch bonding agent. Okay, so this is actually a generation 8 bonding agent. It's a generation 7 universal bonding agent. Universal is sometimes also called as generation 7 in few classifications. So you can use a generation 6, 7 or 8 whenever you have a dentin closer to the pulp. So dentin closer to the pulp, never put any etchant. No 37% phosphoric acid. Only self-etch bonding agent. And after doing etching process, we will be washing the etchant for 10 seconds. And after that, we have three ways here. So now tell me, after washing, you use three-way syringe to dry the cavity preparation, or you blot with a tissue or a sponge or a cotton, or you use a warm air dryer. So what is the usual thing you do in your clinic? So just in the chat box, I want you guys to just tell me. Three-way syringe, blot with cotton, three-way. Okay. Yeah, three-way syringe, three-way syringe. Okay. So whoever told me blot dry is going to be correct. Why? Because whenever we are going to air blow, that is a three-way syringe. I'm having a three-way syringe right here. So whenever you're going to have a blow, right? So your collagen fibers are going to collapse. Okay, so your collagen fibers will collapse. Again, your bonding will get compromised. So never dry the tooth with three-way syringe, and also never dry with warm air dryer as well. 1 second, doctors. So never dry your tooth with three-way syringe because air drying is going to collapse the collagen fibers. Again, your bonding will get compromised. And some articles published, they mention warm air dryer. So it's also very wrong, because why we don't use three-way syringe is because of that air. The force of the air is going to collapse the collagen fiber. The same thing can happen when you're using a warm air dryer as well. So if you come across any articles that says warm air dryer can be used, just ignore it. Even indexed journals also are having this mistakes in them. So like when you come across it, just ignore it. Don't use warm air dryer as well. That can also collapse the collagen fibers. The safest thing what you can do is blot dry with tissue or sponge. So why I don't prefer cotton is because cotton, they have small fibers which get entangled into the cavity preparation, and when you're going to keep composite, it might hinder the bonding and all. So I usually go with tissues. Okay, so I usually go with tissue, a normal tissue, non-sterile one, which we use, regularly, face tissue or something like that. I will be using that to blot dry. The second procedure, what I'm going to, after this blot drying, I will be using I will be using a spread to disinfect the cavity preparation. So that is why I'm not worried about using a sterile cotton. Okay. So here I will be blot drying with any tissue or sponge. You can even use sponge. You can cut the sponges into small pieces, and you can put for autoclave, and you can use those sponges itself. If you are very concerned about sterility, you can do like that. Or if you are like okay, and if you're going to add a disinfection step after this step, then you can actually use a normal tissue itself. Okay, so you can just use a tissue, blot dry, or you can use a sterile sponge. You can just cut sponges into small pieces, put it in autoclave, sterilize it, and you can use it to damp dry it. You just need to damp and dry it. Okay, so no three-way syringe, no warm air dryer. Just dry it with cotton, tissue, or sponge. If you don't have tissue or sponge, use cotton. Never three-way syringe. Even if the cotton fibers get entangled, also that is not a major problem. Okay, so you can just remove it off. Not an issue. But never use three-way syringe. So the next will be ethanol wet bonding. So now ethanol wet bonding, I do it because of two things. One is it will enhance the bonding. The second thing is it will disinfect the cavity. Okay. So these are the two things why I do ethanol wet bonding. But there is a backfire here. The problem is when it is done correctly, it is going to enhance bonding. But when you do even a small mistake in ethanol wet bonding, it's going to completely compromise the bonding. Okay, the collagen fibers which was saved during the etching process, your ethanol wet bonding will actually collapse them. Okay, so you need to be very careful. If you are like very confident that I will do a very good ethanol bonding here, so I will use ethanol correctly, like how I am teaching you. Okay, if you're going to do it correctly, like how I am teaching you, then you follow it. If you have any doubt that somewhere you might go wrong, then skip this step. Okay, because it will compromise. It's two-way, like either it's going to be successful or it's going to be complete utter failure. Okay, if you're going to do it correctly, it is going to be completely successful. If you're going to do it wrongly, it is going to completely, lead to definite failure. Definite sensitivity will be there for the patient. So you have to be very careful when you're doing ethanol wet bonding. So now why you have to be careful is what I will be doing after etching, washing, I will dry the cavity with a cotton or a tissue. I will apply a layer of ethanol. That is normal spirit, which is available in your clinic, like surgical spirit. You will be applying a layer of spirit for 10 seconds, again a layer of spirit, and immediately you have to start with bonding. Okay, so that is very important. Why? Because this ethanol is volatile. It will actually evaporate, right? So when this ethanol will actually replace the water in between the collagen fibers. So the collagen fibers are going to be like this. So what happens is that the water molecules will be there in between the collagen fibers. Okay, so the collagen fibers will have water molecules. Even though we damp dried it, there will be water molecules in between the collagen fibers. So this ethanol will actually replace these water molecules. What it will do is it will remove the water and it will go and stay in that place. Okay, so your ethanol is going to stay in that place. Why ethanol is better? Because ethanol is a very good solvent of your bonding agent. Okay, so if you take a cup of water and if you take a cup of spirit, if you put bonding agent over water and if you put bonding agent over the spirit, your bonding agent is going to dissolve very much better in your ethanol than your water. Okay, so when the ethanol replaces in between the collagen fibers, and when you're going to put bonding agent, your bonding agent completely dissolves on the ethanol and it completely spreads in between the collagen fibers and your bonding is going to get enhanced. Okay, so this is going to be the mechanism on ethanol wet bonding. But if you let the ethanol evaporate, okay, if you take some time in between ethanol wet bonding and bonding agent application, if for example, I applied spirit one layer, 10 seconds, I applied another layer, and after that, I waited for 30 seconds, and then only I placed the bonding agent, it's going to fail because my ethanol would have evaporated, and again, this collagen fibers would have collapsed. Okay, so that is very important. The timing is very important if you're going to do ethanol wet bonding. You apply a layer of ethanol for 10 seconds, again a layer of ethanol, and immediately you put bonding agent. Okay, so you don't wait after ethanol wet bonding, you don't wait, you just immediately put a bonding agent. If you think that you have put too much of ethanol there, okay, if you think you have put too much of ethanol there, what you can do is you can just remove some amount of ethanol with a tissue or something, and you can directly go for bonding agent. Okay, you should never take time in between the ethanol wet bonding and the bonding agent. So these are the articles which are like supporting the ethanol wet bonding. So you can just go through these articles. I think I will be showing you how to do ethanol wet bonding in the demonstration, because these articles are not quite very clear. But yeah, I have been doing it. So this is the mechanism behind it. You just need to replace the water with ethanol in between the collagen fibers, but you should not let the ethanol evaporate. Only then, if the ethanol is still there, only then your bonding agent can come and dissolve into it, right? If the ethanol evaporates, the collagen fibers will collapse. Okay, so this is the mechanism behind it. So I will be showing you how to do it. Only if you're confident that you can next you can do the step. You do not require anything like in between, like you have proper isolation. So isolation is very important right here, because sometimes when you have applied ethanol and suddenly saliva comes in, and you have waited for the saliva, you are going to dry the teeth to the saliva from the teeth, and after that only you have to apply the bonding agent, then it's going to fail, right? So that and all you need to have it in mind. Okay, so you should be confident that immediately after ethanol application, I can within 10 seconds I am able to apply the bonding agent. Only then you take up ethanol, otherwise you just skip it. So now coming to bonding agent application. So bonding agent, many of us have, now started doing bonding agent application correctly. But still, if some of you are like not doing it, I will just tell you how to do it. So when you need to just activate the tooth, okay, you just need to activate the tooth. What you're going to do is you will just apply the bonding agent with a microfiber brush. You will just rub it in the tooth surface. You will just rub it in the tooth surface. And after that, you wait for 10 seconds. Okay. You leave it undisturbed for 10 seconds. And after that, you just need to take your three-way syringe, very mild pressure. So you make sure all the water has gone away. Okay. You keep only the airway. You make sure all the water has gone away. Very mild pressure. So something like this, very mild pressure like this. And then you just spread the bonding agent. Okay, what we need is a thin layer of bonding agent, because if the bonding agent is very thick, it will compromise the strength. If it is not there, it will compromise the bond. So you need a very thin layer. It should be just like a gum. Okay, so when we are going to stick a photograph in the paper, we will just put a thin layer of gum, right? We won't put too much. The same way, you need a little thin layer of bonding agent. So you spread the bonding agent in the tooth surface. Finally, what you will find is a thin adhesive film. Okay, it should be like a frosted glass appearance. Excess, whatever is, after doing a three-way syringe, some amount of excess would have flown here. You can wipe it off with a cotton and make sure no bonding agent is in between the tooth. Okay, it will actually contact, you cannot break the contact then. So make sure you have put a mylar matrix here and you have removed any bonding agent that has gone in between the tooth as well. And after that, you can cure. Okay, so you can cure for 20 seconds. Any bonding agent curing for 20 seconds is advisable. Some lights, okay, some lights will tell you, woodpecker one and all, they will tell you 1 second cure, 2 second cure, 3 second cure. Don't believe them. Whenever you have a higher end light, like if your light is minimum 40 to 50K, okay, so you have bought your light for minimum 50K, then you can believe on the 1 second and 3 second rule. If not, just go with universal 20 second. Okay, just take time, 20 seconds, cure it, and then only finish it off. Okay, so your woodpecker, valiant, and whatever light, whatever lower end models you have, always follow the 20 second rule only. Never trust 1 second. Only when you're going for, like, you can Spectra and Colteen or your Blue Phase N in your Ivoclar, those type of lights, they actually are very costly, like 80K, 90K and all. Those lights, you can trust their 1 second. Okay, so you can cure only for 1 second. All the other lights, you cure for 20 seconds minimum. Okay, so now coming to the bonding agents, what you have to select, how you need to select a bonding agent. So I told you already, your bonding agent dissolves very good into your alcohol, right? So there are many bonding agents are there, like water-based bonding agent, amide-based, ester-based, and ethanol-based. So since your ethanol is a good solvent for your bonding agent, ethanol-based bonding agents are better. Okay, so ethanol-based bonding agents are better. And after ethanol-based, your water-based bonding agents are better. Okay, so either you can go for an ethanol-based bonding agent or you can go for a water-based bonding agent. Whenever you're buying a bonding agent, check what base it is. Okay, so if it is a water-based or a ethanol-based, you can go for it. And after that, you can just categorize the bonding agent like fourth generation, fifth, sixth, and seventh generation. So we will just start with fifth generation. Your fifth generation is a very commonly used bonding agent, where we will have a separate agent, 37% phosphoric acid. And after that, we will have a bonding agent where the primer and adhesive will be together in the bottle. Okay. So with a fifth generation bonding agent, you can do total etch and self etch. So this is actually a fifth generation bonding agent, one coat bond SL, which is quite economical also. 1300 you will get it, 1300 to 500 you will get it. So fifth generation bonding agent, you will like you can do total H, but we don't recommend total H right now, right? Total H is completely out of scope. Okay, so total H should be removed from the syllabus because we can never do total H. Only if your caries is only in the enamel, you can do total H. If it is in the dentin, no option, you have to do selective edge. So your fifth generation, we can do only selective edge. Okay, we can etch, we need to etch, we need to use an etchant. Only then we will be able to use a fifth generation bonding agent. And in case of deeper dentin, we cannot use a fifth generation bonding agent because it doesn't have any etchant inside the bottle. It is not a self-etching one. So deeper dentin cannot be etched separately. So you need to use a self-etch bonding agent. In those situations, you have to go for sixth generation or a seventh generation, most probably seventh generation. Okay. Why? Because your seventh generation is in one bottle. Your sixth generation comes in two bottles, which you will mix and you will use it. Okay. So that is quite, not easy to use. So seventh generation comes in a single bottle, etchant, primer, your adhesive, everything in one bottle. Now they have added a little bit of nanoparticles to it. thereby the etchant. Actually, why seventh generation is not that much successful than the fifth gen? Your fifth generation is going to have the maximum bonding, okay, because it will completely remove the smear layer and it's going to have a very good bonding. While your sixth and seventh generation, they have a compromised bonding because of, their etching. The etching is not sufficient, okay. So the etching happens only for a specific time, or after that it stops. So proper smear layer removal doesn't happen, because of which it doesn't, it doesn't bond properly. Okay. So that is why they introduced something called eighth generation or a universal bonding agent. Now this universal or eighth generation bonding agent, what they have is they have etchant, primer, adhesive, and also some nanoparticles. So these nanoparticles, what they will do is they will have a enhanced bonding. Okay. So they have enhanced bonding. So thereby your eighth generation is going to be much better than your seventh generation. But here, when you're going to do what I am going to tell you, like your selective etch along with self etch, then you can use seventh generation as well. So what you will be doing is deeper dentin, you don't etch, you don't put any etchant on the deeper dentin. But on the superficial dentin, you put the etchant for 5 seconds. And on enamel, you put it for 20 seconds. And after that, you wash it, you dry it, you apply the seventh generation bonding agent all over the cavity, and you will just proceed with the bonding protocol. That's it. Okay. So you can use this one code 7 universal. It is written 7, but it is actually also a eighth generation in some classifications. So you can use it along with selective etch and self etch. Okay. So you can use it as self etch for deeper dentin part, and selective etch with selective etch in superficial dentin and enamel part. So you will mix both together. So in deeper dentin, you will use it as a self-etch bonding agent, where you will not use any etchant, directly apply the bonding agent. In superficial dentin and enamel, you will etch for a lower time, and then you will use it like a selective etch technique. Okay. So this is going to be your protocol. Whenever you're going to follow this, I can just promise you, you will never have any sensitivity issues. Even if you're going to directly keep your composite over the biodentin or something very closer to the pulp also, you will not have much problem when you're going to do this. Okay. If you think if you are very closer to the pulp, what you can do is you can just give a biodentin, a layer of GIC, and then you can go for composite. But always when you're going to follow a self-etch technique in the deeper dentin, you will never have any compromise in the bonding, and you will never have any compromise in the sensitivity issues as well. So now coming to how to select a composite material. So we saw how to etch, how to prepare, and then we saw about what bonding agents we have to select. And then finally about how to select a composite material. So composite material, there are, many, many materials in the market. You can get confused easily. My advice would be to go for select a material, use it forever. Okay. Because why? Because, if you keep on changing the material, you will not be able to know how it performs. So that is a very big, issue here. For example, if I have kept a composite restoration right now, okay, I am someone who regularly reviews my patient, like 1 year, 2 year review, 3 year review, and I have done studies and all, like regarding it, like how the restoration is after 2 year, how the restoration is after 3 year, so those things and all. So I am someone who reviews regularly. So what I do is I use a specific composite on the patient. I write down in their card as well that I have used this composite, I have used this bonding agent, I have used this flowable composite and everything there, so that when any complaint, okay, so the patient comes back with some complaint like I have sensitivity or something like that, I will be able to trace back. Okay, so the problem is because of this composite. Okay, so this flowable is not nice, or I have changed the flowable here. That is the issue here. So I will be able to trace back and see which material is not working properly. So the same applies to you all as well. So write down what material you're using, what brand you're using, what shade you have used, and everything, so that whenever a failure comes, you can actually recognize from where that failure happened, and you can correct it so that the failure doesn't happen again. Okay. So another one important thing whenever you're selecting a composite is you need to know something like uh what is indicated for which. Okay, so there are many types of composite like flowable, bulk fill, and conventional composites. So all those things actually vary how we use it. Okay, so for example, flowable is going to be very the strength wise, the flowable composite is going to be very much compromised. You can never fill an entire cavity with flowable. Okay, so you will never have appropriate strength if you're going to fill the entire cavity with flowable. And on the opposite side, bulk fill has very good strength, but it doesn't have any flow. Okay, opposite side, totally they are in the opposite section. Like flowable, they have very good flow, but their strength is compromised. But your bulk fill, they have very good strength, but their flow is compromised. So that is why whenever you're using a bulk fill, you always combine it with flowable. Okay, but while your conventional composites are somewhere in between. They have quite good flow and also a quite good strength. Okay, so you can always use a conventional composite itself. Make sure you check these things. Okay, the first thing what you have to check is the particle size, the filler particle size. For example, your nano hybrid composites, they have very good polishability. Okay, so because the nanoparticles are very small, when you're going to polish it, it's going to be very smooth and it's going to be very good, maximum aesthetics you will get when you're going to use a nano hybrid composite. But when you're using a micro hybrid composite, your polishability is not there. The composite is actually rough because particles are very huge. The composite, whenever you're going to do the polishing, it's going to get rough. So you will have less smoothness, but the strength is going to be high because the particle size is very big, because of which the strength is going to be high. Okay, you will get maximum strength when you're going to use a micro hybrid. So it is mostly micro hybrid is for the posteriors and nano hybrid is for the anterior, because in nano hybrid you get good aesthetics, moderate strength. In micro hybrid you get maximum strength, you don't get that much of aesthetics there. So your micro hybrid is for your posteriors, your nano hybrid is for your anteriors. Now you get something in the market, something called submicron hybrid. So submicron hybrid is nothing but in between the nano and micro. So it's not very small like nano, it's not very big like micro, it's something in between. So this submicron hybrid composites, they have both. They have good aesthetics also, they have strength also. They can be used in anterior also, they can be used in posterior also. Okay, so one such composite is your Brilliant Everglow. And it's quite not like, okay, yeah, it's in a mid range, and it's quite good. You can use it for anterior and posterior as well. If you want a specific micro hybrid, you can go for Swiss Tech. Okay, so this is a specific micro hybrid which is quite economical, and a complete micro hybrid focused only for the posteriors. So you'll be getting a flowable composite and also a packable composite here. So you will be putting a layer of flowable composite, and on top of it you will be doing in incremental techniques. But both of these are conventional composite. They are not bulk fill. They are not actually any bulk fill. Okay, so they cannot be used in thick layers. They need to be done only in incremental layers. Okay, so micro hybrid for posteriors, nano hybrid for anteriors, submicron hybrid can be used for both anterior and posterior. It will give both strength and aesthetics. Now coming to something called your bulk fill composites. So whenever you're using a bulk fill composite, you have to always use your flowable composite as well. So we will be putting a layer of flowable composite. On top of it only, we will be using a bulk fill composite. Now the major problem is most of the bulk fill composites are nano hybrids. Okay, so most of the bulk fill composites are nano hybrids. You will not believe it. Your Tetric Evo Ceram, Voco Extra Fill, they are like premium materials, but they are nano hybrids. Okay, if you go and check, it will be written there. It is a nano hybrid bulk fill composite. Now we have a biggest problem. Do we want a deeper curing area, or do we want strength in the restoration? So it's up to you. Okay, you have to decide what you want here. If you're using a bulk fill composite, very good. No problem at all. Just put a flowable. Don't cure it. Put a bulk fill, and then after doing all the carving and everything, you will just cure it. So we will be doing something called a snowplow technique, something like this. So where we will be putting the flowable here. We will not cure it. Just add the bulk fill here, bulk fill material. The flowable will just flow. The excess of the flowable will just flow out, After doing all the carving and everything, you can just cure it off. Okay. But the problem is all the bulk fill available in the market is going to be a nano hybrid. You will never get a micro hybrid composite in a bulk fill. Okay. So I can challenge you, if you find anything micro hybrid as well as a bulk fill, do let me know. Okay. And actually, this was there. This Tetric Evo Ceram was actually a micro hybrid bulk fill, but it is not available in India right now. Okay, it was there till the lockdown. 2020, it was there. It was coming to India, but after lockdown, it is not available in India right now. So we are out of any micro hybrid bulk fills in India. We have only nano hybrids here. And coming to the incremental technique, so you would have understood something like microhybrids are available only in conventional composites. So we cannot skip incremental technique, right? We cannot skip. If we don't want to compromise the strength, we have to go with incremental technique. So incremental technique, you have many incremental technique, oblique, straight, vertical, horizontal, many things are there. So now what I recommend is a split incremental technique, which I will be showing you in the hands-on as well. Okay. So in the demonstration as well. So what we will be doing is we will just decrease the wall floor contact. Okay. So to reduce the polymerization shrinkage, we will reduce the C factor here. So when we reduce the C factor, automatically the polymerization shrinkage will reduce. So how to reduce the C factor? We will just decrease the wall floor contact. So one increment should be in contact with minimum wall or minimum floor as possible. So we will keep the first increment in such a way that this increment will be in contact with only one wall and one floor. Again an increment, one wall and one floor. Again an increment, one wall and one floor. In such a way, we will keep floor 4 increments, and after that in between, we will keep one increment. Here also one wall and on one floor, and again the same here. So when we are going to do the split incremental technique, we will achieve something like 0.5 C factor so that the polymerization shrinkage is completely reduced. Okay. So your wall floor contact in general, we will reduce the wall floor contact as much as possible. So if you are keeping an increment, we will make sure it is contacting less floor or less wall as possible. Okay. So at a time, it should contact only one floor or a one wall or a one wall and one floor. Okay. Now coming next to your light emitting, your LED lights. So your LED lights, I would recommend you to buy a very standard light. Okay. So make sure you buy a very good light, minimum 20K. Okay, you can go with Ivoclar wired one, or you can go with the recent one launched in Colteen, like I think Colortex, I guess. Yeah, that is also very good. It's economical. So try to buy a light. You have done everything correctly. Okay. Just because the light is not standardized, you don't want your restoration to go wrong, right? So light is like one-time investment. I have Ivoclar lights, I have Colteen lights and everything. I have been using Ivoclar light for more than 8 years. Okay, it has been in a very good condition because I maintain it very good. But the same applies. So once you buy it, it's going to be for lifetime. So just invest on your light. Have a standard light. Okay, so minimum 25K you have to spend on the light. So never compromise on the light. Only then you will get the wavelength 400 to 500 nanometer, which is going to be the correct wavelength to cure a composite. So you will have very good curing. And because of that, your restoration shouldn't fail, right? So invest on light, which is going to be one-time investment in your clinic. So always invest on light. So, and another thing which I want to highlight is whenever you're doing a class 2 composite restoration, after completing the composite restoration, after removing all the matrix bands and everything off, you have to just cure from the sides. Okay. Why? Because whenever you're curing from the above, you're the closest part, from the above, the light is not very closer to the deeper part. When you're curing from the side, it is very closer to the deeper part. Okay, so if you would have noticed, so always finally class 2, always cure from the sides. And another one important thing, what I would recommend is pulse delay curing. Okay, so pulse delay, so there are many techniques of curing. Uh, Rampant curing, slow phase curing, and many techniques are there. So this pulse delay curing is nothing but you just delay the polymerization. Okay, you just delay the polymerization. How it is done is, so nowadays you get the light with where you can keep the settings in low intensity and high intensity like that. So what you will be doing is, first you keep the light in low intensity, you incident it for 3 seconds, then switch off the light, leave for 10 seconds, and after that again on high intensity you incident the light for 10 seconds. Okay, so this is actually pulse delay curing. So what happens is, when you incidented the light at low intensity, the polymerizations would have started. Okay, so after you gave a rest period, it would have actually quite aligned, the monomers would have aligned, and after when you put the high intensity, the polymerization would have completed. Okay, so to complete the polymerization, completely do the polymerization, you can do something called pulse delay curing. First 3 seconds, low intensity, and then after that without light for 10 seconds for the alignment to happen. And after that, you cure at a fletch with high intensity for 10 seconds. So this will actually complete the polymerization, so there won't be any shrinkage. So the final thing which we don't do is not using appropriate instruments to do a composite restoration. Okay, one of the major problems, most of my students, they tell me, ma'am, I do a good composite restoration, and finally I do all the carving, and after the patient bites, there is high points, and I make the restoration flat. So how to prevent that? So that is going to be the major doubt which all my students ask me. And I ask them a question in return. When you were doing amalgam restoration in second year or third year or final year of your BDS, did you ever have high points? No, no one had. Okay. So we never had high points when we did amalgam restoration. In fact, amalgam restoration, we don't know, many of us did not even have amalgam polishers with us. Okay. We did without the polisher. We used to just rub the cotton with, a ball burnisher. We used to just rub it and make it shine. We used to not even use the polishing kit, amalgam polishing kit. So no one ever had it. Okay. We used to never reduce anything also. It was just perfect. Patient never had any high points. Why? Because we used to carve the amalgam. Okay, that is the mistake which is done here. We are not carving the composite. Why? Because we are not using an appropriate instrument to carve the composite. So that is the reason here. You have the technique. You know the carving already. What you are doing for the amalgam, the same thing you need to do to the composite. But you need to buy some instruments. You need to use some instruments so that you can carve your composite as well, like how you used to carve the amalgam in your college. Okay, so the same thing, you have to carve the composite like how you did with your amalgam. How you never had high points even, without polishing, the same thing you're going to do with the composite as well. Only thing is, you need to invest on the instruments that can carve composite. So one such instrument, or the only such instrument in the entire world, is going to be your LMArt instrument. It is completely designed for composite. And another one reason why I recommend Brilliant Everglow. Okay, so why I recommend Brilliant Everglow is, Brilliant Everglow composite and your LMArt instruments, everything is actually designed, and it is actually invented by your Style Italiano members. Okay, so LMArt instruments, your Brilliant Everglow, everything is designed according to your composite restoration by Style Italiano Golden members and all. Why? Because they are like frequently doing, and the basic motto of Style Italiano is to simplify the techniques. Okay, so if I'm doing a composite restoration, I shouldn't do it very complicated. It should be very simple. Okay, so that is how the instruments and the composite material is designed. So that is why I recommend these two materials as well. The same way I recommend LMArt instruments. Okay, so there are instruments which resemble LMArt in GDC also, it is available. In Denmark, it is available. So I have also used everything, but you will not get anything like LMArt. Okay, so I will just tell you, once you start using LMArt, you will not go back in it. And all we are actually training our students in LMAT only. So like LMAT is going to be your only instruments with which you can give a perfect composite to the patient. Okay. So no matter what you have done it in the previous, like etching, bonding, everything, if you have done correctly, if you are not doing if you're not using an appropriate instrument for the composite, then it's going to fail. So you have to have a proper instrument, even if you are not able to buy all the instruments. So it's not necessary like you invest 30K and you buy everything. Okay. So buy all the, like if you want to buy 8 instruments, you have to invest 30K. You don't invest that much. Just buy few important instruments. You can buy single instruments also. Sometimes a single posterior instrument is enough to do a complete posterior restoration. Okay. So that is how it is. So for example, this is a posterior replica. Today we will be showing you a demo with this posterior replica only. So this posterior replica with this a single instrument, you are able to carry the composite, you are able to compact the composite, you are able to carve the cusp, you are able to carve the fissures and your pets and your fossas and everything you are able to carve with one single replica posterior. So this replica posterior is a must instrument which you should have in your clinic. I will be showing you in your demo why it is very important. And the second one will be your anterior replica. So anterior replica, with this single instrument, you are able to carry the composite, compact the composite, you are able to carve the margins, shape the margins, bring the, this triangular patterns and replicate the anteriors and everything with a single instrument. So replica anterior is also a must. And additionally, if you want, so you need not buy the entire instrument. You can just go with replica posterior and a replica anterior. With a single replica anterior, you can do the entire anterior restoration. If you want to add some more instruments into your clinic, then you can go with a solo anterior. So this solo anterior is also for an anterior. So this actually, when you're going to work with this on the composite, it's just going to smoothen the composite, and literally you need not do any polishing at all. Okay. It's going to smoothen the composite to the maximum level, the curvature of the tooth. And when you're going to use a anterior solo anterior and a replica anterior together, the orange one and the yellow one together, you can just do a very fine work in anteriors. Okay, you need not use any other instrument. Just these two instruments are enough to do, almost a perfect work, which is acceptable entire world. You can even submit your work to the Style Italiano. So that much perfect work you can do with just these two instruments. And if you want, you can add something called fissura. So this fissura is important to give some mamelons for the fissures, to deepening the fissures, the fossas and everything, to do much more minute works. It's not compulsory to have, but you can have it just to, in addition to do much more, very detailed work, you can add a fissura. And this is something called exciso. You will find it, you will not find it anywhere. This exciso is actually, it will cut cured composite. Okay, so after curing also, if you think the surface is rough, you can just scrap it off with exciso. It's just like your, how you scrap off your amalgam, right? After it sets, the same thing. So you require a very good instrument to carve the composite. You know the technique. Actually, you have been carving the amalgam in your BDS. The same thing you have to do with these instruments. Okay, no one actually, you do not require anyone to teach you because everyone knows carving. You just need to buy the instruments and use it in your clinic. That is how it is. So you have to just start using it. Use these instruments, carve properly so that you do not have any high points. The restoration merges with the tooth structure, and it actually, you are able to reproduce the functionality, and there won't be any issues. The patient is going to have, you can give a predictable composite restoration in the patient once you start using these instruments. And your polishing protocol. So never use your burrs. So you would have understood something. Okay. So whenever you're using a LM art instrument, you will never have excess composite. Okay. You will never have excess composite once you have started carving the composite. You will never require your yellow finishing burr to remove excess composite, like usually how you do. When you have started carving the composite, you will automatically require just a little bit of contouring and a little bit of polishing. So you can totally ditch your polishing burrs. Okay. So you have started using LMR instruments. you can actually not use your finishing burrs at all. Your finishing yellow grid burrs, never take them out. Okay. So either you can use a carborundum burr like this to do contouring, or you can go for super snap black coarse one. Okay. So I don't buy the entire kit. I buy only the black one. Okay. So this is going to be very coarse one. I will just remove the excess of, smoothen it, and just a little bit of finishing. And after that, I will be going for the polishing. So polishing, you can use any polishing kit, dense ply, shofu, Colteen, Kenda polishers, anything you can use. Okay, it's up to you. I would not. I have been using Kenda polishers. I have been using shofu, and I have used a dense ply also. Everything is same. Okay, so I don't feel anything is superior to anyone. Everything is same. Even the polishes which is available in the Dentmark also I have used. Okay, something like 800 rupees, 1,000 rupees, which we give for the students in the hands-on. Okay, so those are also very good only. The only thing is, how much ever costlier you buy, it is going to wear off. Okay, once it is going to wear off, you have to throw it away. So even if you buy for 800 also, even if you buy for 8,000 also, it will wear off. The cases, number of cases is going to be more. If you are going to buy it for 8K, it will come for around 10 to 20 cases. If you're going to buy it for 800, it is going to come to 2 or 3 cases. That's the only difference I find. Other than that, it is going to be effective. Okay, so everything is same. Number of cases you can use, just that differs. So whatever polishing you're going to use, just start with the coarse, then go to the medium and fine. Okay, so in posteriors, you need not do this. Okay, just your finishing would be sufficient. After this, you can just go to a smoother one, or a finer one, or a very fine one directly. You need not do a 3-step polishing or a 2-step polishing when it comes to posterior. In anterior, you never skip. Okay, first coarse, contour, and after that you go for coarse one in the polishing kit, then medium, and then you're fine. And the color varies a lot, doctors. You shouldn't like, that's why I'm not mentioning you put white, then green, then yellow, then your pink. Why? Because it varies a lot. Each system has their own color system. Okay, so Colteen, your coarse is white, then your medium is green, and your fine is pink. But in shofu it's quite different. Okay, so it varies a lot. So whatever the manufacturer has given, first, second, third, or coarse, medium, and fine. So whatever the color coding that has been given by the manufacturer, you can follow the same. Coarse, medium, and fine. And after that, finally, your finishing should be done. Your final finishing should be done with a Jiffy brush. So this is a Ultra Dent Jiffy brush. You can just use a polishing paste. Primagloss Dentsply is very good. Another economical option would be to go for Prime. Okay, Prime is very good. High gloss. Okay, Prime high gloss is also very good. If you want an economical option, you can go for Prime high gloss, or you can go for Primagloss Dentsply, and just apply a little bit of your polishing, and then you just work with your Jiffy brush. That is going to be your final polishing. Okay, so no matter your anterior or posterior, your finishing step should be Jiffy brush plus your composite polishing paste. So once you do this, you will get a very smooth, seamless restoration. Your patient will never have any food lodgement, or never debonding, or no marginal gaps, and no sensitivity is going to be there if you're going to follow all these steps. Okay, so just can we have the demo right now? Like, I will just take a 5 minutes break so to set up for the demo, and I will come back. Okay, please wait for the demo. Am I audible, doctors? Am I audible? Am I audible? And I hope my screen is clear too, right? Yeah. Okay. So we'll just start with the demonstration today. So this is a model which we usually use for hands-on. So here I will be showing you just a class one composite today. I will be just showing you a selective etch how to do and how we will be going about the other technique as well. So starting with cavity preparation. So here we haven't given any bevels. If you can see, a little bit of bevel has been given. This is a model of a patient only. Uh, so here you can see a little bit of bevel has been given in the borders. So this bevel you have to give whenever you're doing a cavity preparation. So the inner parts you will prepare using a carbide burr, and after that you will just use a ball shaped burr and give a bevel in the margins. Okay, so that is going to be the preparation part. So starting with the etching. So the etchant which I recommend would be Meta Etch. Okay, so the recommended etchant would be Meta Etch. So why Meta Etch is going to be very thick. So if you can see, this is actually a Valdent one. Okay, so best etch. So this also doesn't flow, but your Meta Etch is quite thick. Okay, so when you're going to place it only on the enamel, it will stay only on the enamel. It will not flow anywhere else. So that is the benefit of using Meta Etch. But you can use any etch. So what I'm doing is I'm actually doing a selective etch where I am etching only the enamel. So this much clearly you will be able to do in the patient only if you have a rubber dam on. Otherwise, you will have saliva and all other problems as well. So if you want to do a perfect composite restoration, a predictable one, better go with rubber dam. Okay. So without rubber dam, the story is not complete. So just etch the enamel. I have put etchant on the enamel, and I will be waiting for about 10 to 15 seconds. And after that, I will put etchant on the dentin as well. Okay. So if my floor is closer to the pulp, I will not etch that surface. Okay. I will etch only the superficial dentin. I will not etch the floor which is closer to the pulp. So I will be etching the enamel and also the superficial dentin only. I will not be etching the deeper dentin which is closer to the pulp. So now what I will do is I will just wash it off. Wash everything off. Why no water is coming here? 1 second, doctors. இது செக் பண்ணலையா இதேதான் லைவ்ல கூட பட் ஏன் வை கம்ப்ரஸர் ஒர்க் ஆகுது சரி ஜஸ்ட் யூஸ் இதுலயும் வரல 1 second, doctors. Air is coming, only water is not coming. Okay, I will just wash it off. Syringe. Give me one syringe. So here we are not going to etch the deeper parts of dentin. Okay, we are etching for a long time. I know. I will just wash it with a syringe. Okay. Right. Give me 2 minutes. It's just a small problem here. Three-way syringe, there is no water coming in our hands-on unit. That's why. Meanwhile, I'm just keeping a piece of cotton or a tissue paper ready. Okay. So this is a normal facial tissue which I will be using. I will just take a small part of facial tissue. I will just roll it, make it look like a cotton, and I will just use it. So make sure your tissue is also, some tissues when they become wet, no, they leave some water, a little bit of fibers in them, right? So make sure that doesn't happen here. Syringe or give it syringe. Later. Keep them off. It is in off, I think. Booster bottle. So I'm just washing it off. Instead of three-way syringe, I'm washing it with syringe. Okay. Because the water is not coming. So right now we don't have time to see that. So after that, I have just taken a pellet of tissue. So I will just use my tweezer. Just wipe it off. So even the tissue can leave some fibers inside. So make sure your tissue doesn't do that. You can just take another one, a little piece of tissue. Make sure you have damped it dry. After making sure it is completely dry, now what I'm going to use is I have taken some seventh generation bonding agent. Okay. So seventh generation bonding agent, which I have been using. This is also, we use it for hands-on fusion bond, but not for the patient. Okay. So in patient, I recommend only one coat, or you can go for Ivoclar. So in hands-on, in models and all, we don't, spend too much of money. So that's why we are using this. Otherwise, in patients, I recommend one coat, or you can go for Ivoclar Universal, and you just take a little bit. So here, if you want, you can add a step of spirit. Okay, so you can do alcohol wet bonding if you want, but you should be very sure. Okay, so here I can add that step. So I will just put a little bit of alcohol into my well so that I can use that. Okay, so I have put a little bit of spirit in my well, and I'm using a separate applicator tip for it. This is the applicator tip which I'm using for the alcohol. I will just dip it in the alcohol, just rub it a little bit, leave it for 10 seconds. Then again, I will just rub it, leave it for 10 seconds. Whatever excess alcohol is there, I will just remove it off with this time be better use a sterile cotton. Okay. So this time better use a sterile cotton. Within 10 seconds, it will start to evaporate. Can you see it is evaporating this side and all? So just if you have excess, use a sterile cotton, just damp dry it. Okay. So no need to rub it. Just dry it, damp it off, remove the excess alcohol, then straight away go with the bonding protocol. Okay. So straight away apply the bonding agent. So now the bonding agent would have actually infiltrated into the collagen fibers much better because of the presence of alcohol. Just activate it. Can you see? Just rub the surface with the bonding agent. May it be anterior or the posterior, just rub the surface for 5 seconds. Okay. Then leave it like that for 10 seconds. And after that, thank God our airway syringe air is working. So, like, can you see? I will let go of all the air, and this is the maximum pressure. But what I will do is I will just use this much pressure. So this is the maximum pressure. Can you see my gloves moving? So I will be using a mild pressure here. Okay. So instead of maximum pressure, I will be using a mild pressure. So I will just use a mild pressure and I will just, can you see my bonding agent moving? So this is how it will move. Can you see the excess bonding agent coming out? Air blow in all the direction with mild pressure. Okay. And with the cotton. So ultimately you will have a very thin layer of bonding agent. Okay. Ultimately you should have a very thin layer of bonding agent. So whatever excess is there, I will just wipe it off. இல்ல இல்ல எனக்கு அந்த லைட் தான் வேணும். Plug in பண்ணுவீங்க. அந்த அந்த இடத்துல plug பண்ணுங்க. So wipe off the excess. So here I'm using the tissue, okay, which is beside me, but I would prefer to use a sterile cotton when I'm doing it on the patient. Okay, so you can just wipe it off. And if possible, here, you know what mistake we will do is some of the bonding agent would have gone in this gaps, okay, in between the teeth. So after curing, it becomes closed. Okay, so always make sure you put a mylar matrix here. Make sure there is no bonding agent in between the teeth. And after that, you go for curing. Okay, so now we will cure. This is Ivoclar light. So if you can see, this is Ivoclar light. So we will just cure it for 20 seconds. This Ivoclar light is the first light which I bought. So it's like it has been with me for a very long time. Nearly its 8th anniversary is over. So like it's very good. Okay, it's a wired one, not a wireless one. It's a wired one, basic model, Ivoclar. This model has been stopped actually. Right now it's not available. So for 20 seconds, that's it. And after that, we will be proceeding with our composite part. So now we might require something called restorite. So this is a modeling resin. Uh, Modeling resin makes the composite smoother. Okay, so whenever we are doing any carving procedure or something, I prefer using modeling resin. So some people have a habit of using bonding agent over the composite. So don't do it. Buy something like this modeling resin. So it is available in Voco and in many other good brands as well. So Voco is very good. And if you want, you can even go for Prime also. Not very bad. Just use little. Okay. So you should not use too much of modeling resin. It will compromise the strength. You have to use very little modeling resin. Okay. So I can do two things. One is I can use a gun. Okay. So I have a gun here. So since it's a posterior restoration, I can use a gun. So I will just keep a increment of composite with a gun. Okay. So now what I will do is I will just take an LMArt instrument, posterior replica. So this is posterior replica, which I showed you. So I will just this is the increment which I was talking about, split incremental technique. So if you can see, my one increment is in contact with one floor and one wall. Okay. And after that, I will just cure. If I think that the floor is actually very smooth, so that's why I have started with the composite itself. So if you think that your floor is not very smooth and you want to use a flowable, so if you think that the floor is not very smooth, you require to use a flowable, you can just place a very thin layer of flowable like this, a very thin layer of flowable. Can you see how little flowable I'm using? Yeah, very thin layer of flowable. Okay, just to cover the irregularities or something like that. Nothing more than this. Okay, only this much you have to use. Only when you think that the floor is very irregular. Otherwise, you can just proceed with the fillings. And what is the difference between using a compule and syringes? Nothing much. Okay, sometimes the compules you can heat it, but I don't believe in heating the composite because when you heat the composite, polymerization shrinkage is more. So I don't believe in heating the composite. But only thing is it can be sterile. Since one compule can be used only for one patient, it will be over. Okay, so with one patient or two patient itself, it will be over one single compule. So it is actually much more sterile than your normal syringes. Other than that, you don't have any other benefits in using a compule. So here I'm going to take a syringe now, just to show you guys. Syringe also same. If you have a bulk fill, you can just fill it up. Okay, you can just fill the entire cavity. No need to do any increments like how I'm doing. But right now, what I'm using is a Brilliant Everglow composite. Okay, so Brilliant Everglow is a universal submicron hybrid composite, but it's actually a conventional composite. It's not a bulk fill composite, so I have to do it in an incremental technique only. So I don't have any other option. But what I'm doing is I'm actually putting four increments at a time because this is a split increment technique. I am able to do it like this as well. I will make sure one increment is not touching the another one. Doing it for 20 seconds, keeping it as closer as possible to the tooth so that it's completely getting cured. So in anterior, actually, after every increments, I will be using Restorite, this sculpting, composite sculpting agent. But in posteriors, I don't use that much. Only while carving, I will be using it. Okay. So final carving, when I'm doing, I will be using it. So in between the increments which I have placed previously, I will just fill the composite in between. You need to practice a lot in the models. Then that is when you can be able to do incremental, split incremental technique in the patient. It's quite difficult to do in the patient at the first go itself because here I'm having the model in my hand and it's quite easier to do like this. But when you're patient, it's quite difficult. I know I have been through it. So it's better you practice on models. Okay, have typhos and practice beforehand on expired composites or something so that you can easily do it on the patient. Okay, so I have kept an increment. So from here, I think that I will be using a little bit of Restorite. So I will put my Restorite in the middle well. So if you can see the color difference between the bonding agent and the Restorite, you are able to see that it's lighter in color. Okay, so it's lighter in color. So I'm just using a brush. This is a dental grade brush. Okay, and you see how it's sculpting it. And another one very important thing what I will be using is a silicone brush. Can you see how the composite has smoothened out? How the composite has smoothened out? But make sure you use very little of sculpting, okay? Because it will compromise the strength. Because in posterior, strength is very much important. So that's why I'm not using that much. Cure it. Then again, another one increment. So I'm using a single instrument only, the same posterior replica. So this is the only instrument I will be using throughout till the end, till the cusp carving and everything. So I'll be using only this instrument from the beginning to the end. Can you see like how I'm able to carve the cusp? Can you see how I'm able to carve the cusp right now? So from here, I will be starting to carve a little bit because we have almost reached the top. Then if I keep some excess material and without carving, if I cure, I will not be able to do any carving. That is also a disadvantage of doing incremental technique because we cannot do carving afterwards, after the composite is cured. Like unlike your bulk fill, we are able to like carve and everything do, and then only we will be curing. But in incremental composite, you are not able to do that. So initially itself, you should start carving a little bit. So now I will just add a little bit more composite. Merge a little bit with the tooth, and then I'll just start carving it much more clearly. When I'm doing this itself, try to remove the excess like this. You can remove the excess of. You can remove the excess of like this. Just your instrument is designed in such a way you need not do anything. You just need to do whatever I'm doing. You will get the same results what I got. It won't be much very difficult and all. It's quite easy. This you will have a acceptable restoration with posterior replica only. You will have a acceptable restoration with posterior replica only. But if you want a very good, or you want to refine it much more, you want it more, naturally replicated, then you need to invest a little bit more on a fissura as well. So here, a fissura, I'm able to refine the fissures and the fossas much more better, just like your conical burnisher. Okay, so whatever your conical burnisher did, the same thing your fissura, this end will do. Okay, it's similar to your conical burnisher, whatever you are using for your amalgam, create the fossa, and your fissura will create. This is a thin tip. So finally, with your restorite, just smoothen off. That's it. And it's not muted. I'm just not talking anything. So you can just remove the excess of this restorate as well by air drying a little bit. Okay. And then final curing. This time cure from all the sides. So whenever you're curing in the final, may it be class 2 or class 1, cure from all the sides. Okay. So pulse delay curing is nothing but you cannot do pulse delay curing in this. This is actually a older one. So if you want to do pulse delay curing, you need low intensity, high intensity modification. That setting should be there in that light. Otherwise, if you have a normal light or older light like mine, what you can do is from far away, you can just cure from far away. That is actually a low intensity, right? So you can cure from far away and then switch it off after 3 seconds, leave it for 10 seconds, and then come closer and cure it for another 110 seconds. So this can be a pulse delay curing if you're using a normal light. So otherwise, you can keep it in low intensity, 3 seconds, switch it off, leave for 10 seconds, and then again keep it in high intensity settings and cure it for 10 seconds. Okay, so this is going to be your pulse delay curing. So if you want to do correct pulse delay curing, you need a light in which you can change the settings. Okay, so now finally cure from all the sides. Okay, so cure from all the sides to make sure that complete curing has happened. So can you see how far the light is traveling? Because your tooth is actually, it transmits light to an extent. Okay, so you can be sure when you're curing from all the sides, you can be sure that it's completely getting cured. Okay. So for posterior, almost if you can see, I don't have that much of excess here. Okay. So I don't have that much of excess and it's quite smooth. But this is not sufficient for me because it's a little bit rougher only, according to me. So what I will do is I will smoothen it out a little bit. I will not do too much of polishing. I will just do a mild polishing according to posteriors. So what I will do is I will just take a coarse one from usually for posteriors we will be using this pointer one only. So I will just take a coarse one, the white one. And whenever you're using a polishing cup like this, so you should not use it on you should not use it on rough composites. Okay, so for example, if my composite is not smooth, it's rough, I'm not supposed to use this directly on it. Okay, so what will happen if I use a rough, if I use this rubber cups on a rough composite is there will be scratches in this rubber. Okay, this will come off. So always make sure your composite is smooth, only then you use rubber cups. Okay, so I'm using a coarse rubber cup. I'm keeping it in maximum speed. Whenever I'm using a polisher, I will keep it in maximum speed. But when I'm contouring it, so when I'm using Shofu coarse one, I will keep it in medium speed. But when I'm doing polishing, when I have started with a polishing kit, I will always keep it in maximum speed. Okay. This much of polishing is enough. Okay. So this much of polishing is enough. Final polishing with your polishing agent. I will just use a polishing paste. You can go with dense fly one or you can go with prime. Both are good, but dense fly one is more premium. So if it always depends on how much the patient is paying you. Okay, so if the patient is paying you good, then you use premium materials. If not, you use medium premium materials. That's it. Okay, so nothing to argue about that. And this also I will keep it. So this is a Jiffy brush. So this is a Jiffy brush of Colty, not Ultra 10. So Jiffy brush, you have to keep it in high speed, highest speed. Okay. So we will just, so before doing polishing, check for high points, doctors. Okay. So if you want to make sure that the patient is not having any high points, before doing polishing, when you're doing contouring itself, you can check for high points so that the patient, whatever high point, a little bit here and there, if it is there, you can correct it. And mostly if you're going to carve properly, okay, according to the tooth structure, according to the opposite tooth and all, usually you will not have any high points. Okay. So just do a final polishing with the paste. We will just wash it off. This blue color paste will go off. Okay. It's everything is polishing paste only. It will go off. You need not worry about that. It's just that the force of the water is not that much. So in three-way syringe, when you're going to do, it will go off. So that's it. So this is a approximately how you are supposed to do a posterior composite, predictable one. When you're going to follow all these steps, you will have a very good restoration. So if you can see, the restoration merges with the tooth structure. There is no reason for it to have any high points mostly. Uh, it might be there, okay? It might be there. So you just need to check before doing the final polishing. Okay. So any doubts so far, doctor? So we will have the question answer session right now. Okay. I will just take a 2 minutes break. So I will come back to the laptop. I'm in my phone. So I will come back to the laptop and we will have a question answer session, quick 15-minute session. and we will wind up. Okay. ಅದು ಆನ್ಲೈನ್ ಕನ್ನಡ. Okay, so I will just address the question answers right now. So let me go to the starting. Yeah. In many class 2 caries, there is gingiva coming over the tooth. How to manage this and restore the tooth? Because when we touch this tissue, it will immediately start bleeding and it doesn't stop easily. So, how to manage such cases? So, doctors, whenever you have a gingival overgrowth, okay, so gingival overgrowth is actually you need to cut it off and it is going to bleed. So, either you can use a hemostatic liquid, okay, which is available in dental cart and all, hemostatic liquid where you can dip it in the cotton and place it there. You should not place it for a longer time because it will actually necrose the gingiva a little bit. So you have to keep it for a little bit of time, and then if you feel that bleeding has controlled, you can proceed with the restoration. Alternate option is you when you're going to cut, you can use a electrocautery. Okay, when you're using a electrocautery or laser to cut off those tissue, mostly bleeding won't happen. Okay, so that is how I do it. But in case if you're not able to do in that way as well, so if you don't have a laser or a electrocautery to cut off those tissues, you're using only burr or your scalpel to cut. If it's bleeding too much, don't do the restoration on the same day. Okay, just give you can give a zinc oxide eugenol pack. Okay, so zinc oxide eugenol, normal zinc oxide eugenol, which you use for as a sealer and all, right? The same thing, zinc oxide eugenol, mix it into a thick paste and keep it over the tissue or in that space and leave it there for 1 day. Automatically, the bleeding would get arrested. Next day, you can call back the patient and do the composite restoration. So you can do it in 3 ways. One is you can use a hemostatic liquid. You don't use it for a longer time, your gingiva might get necrosed. The second thing, you can use a laser or a electrocautery. Bleeding won't happen when you're cutting the tissue. If not, you can just cut the tissue, arrest the bleeding, leave it 1 day with a zinc oxide eugenol pack, and later call back the patient and do the restoration. So you can, after 1 day, you can call back the patient and do the restoration. So you can do it in this way, doctor. And next doubt. Yes, doctor, round burr, carbide round burr. It is there. You go and search, you will get it. And RMGIC, I usually go for Ivoclar, doctor. Cention, that is my go-to one. You get that syringe also, which like you can readily mix and you can readily put it there. So you can either use the capsule one or you can use the syringe one also. Class 5, no doctor. Only if you're bonding with enamel dentin, composite is fine. If your class 5 is somewhere near the cementum, no, go for GIC instead. Don't go for composite. For deeper caries, is etching totally avoided for deeper dentin close to the pulp. So total etch we will never do now. So now all of you are never going to do total etch. So whenever you have a deeper caries, deeper part of the dentin should not be etched, like how I showed you in the hands-on, right? So how I showed you in the demonstration, the floor, I didn't touch the floor with etchant. So the same way, deeper caries closer to the pulp and all, you will not etch, you will directly use generation 7 bonding agent, 1.7 or something like that. Directly, a self-etch bonding agent should be applied. Mm, then 3D syringe. Ethanol wet bonding can be avoided when closer to the dentin. Okay. So in deep caries, ethanol wet bonding can be avoided. Why? Because already the collagen fibers are very less. We shouldn't risk evaporation of ethanol and collapse of collagen fibers. So it's better when you're in deeper dentin, you can skip ethanol wet bonding. And yeah, you have to apply ethanol on all the surface of cavity preparation, doctor. Wherever there is dentin, you can apply ethanol. Finishing instruments should be used after curing. Okay, so if you're using a finishing instrument like your finishing and polishing kits, it should be used after curing. Glycerin, I don't recommend, doctor, because we are doing a vigorous polishing protocol. Okay. So, what is the purpose of glycerin? So, to prevent the oxidation inhibition layer. So, whenever we are curing a composite, there is an oxygen inhibition layer formed. So, oxygen inhibition layer will help composite bonding. So, it is recommended when you are doing incremental technique. But the final layer, when it is having oxygen inhibition layer, it will take up stains. Okay, so that is the basic mechanism. Now we are doing a very good protocol, polishing protocol, where we are removing the superficial layer. Okay, we are removing the superficial layer at all. We are completely coarse, fine, medium. We are completely removing a little bit of superficial layer, which is actually the oxidation inhibition layer. Okay, so there is no requirement for you to do glycerin. Add a layer of glycerin before curing if you're doing a proper polishing protocol. If you're following a proper polishing protocol, you will be removing that inhibition layer during your polishing itself. So there is no requirement for you to put glycerin while curing your final cure. Can you please take a webinar on post and cure? Doctor, come join our classes, comprehensive endodontics. We will take elaborate class on post and core only. Composite restoration color change over time. Okay. If you're doing everything what I have done right now, and if your polishing protocol is up to the mark, you have removed that oxidation inhibition layer with polishing, or like how doctor told, final layer, apply a layer of glycerin and cure. Oxygen inhibition layer won't be there. So if you have followed those techniques, and if you have followed a proper polishing technique, your restoration should not discolor. But even after you being perfect, sometimes your restorations can discolor, and it is not in your hand. Okay, so that is the truth here. So one of the major reasons why restorations discolor even after doing it perfectly is because of the photo initiators which are present in the restorative material, in the composite material. So there are two types of photo initiators in general. So there are type 1 photo initiator and type 2 photo initiator. Your type 2 photo initiator is a major photo initiator which is used in most of the composites that is available in the market. That is your camphor quinone. That is a type 2 photo initiator which requires a co-initiator like amine to work with to produce free radicals. So this amine actually causes yellowish discoloration in the restoration. So any composite material you're using which has camphor quinone will have amine, and which will cause yellowish discoloration after 1 or 2 years, no matter how perfect you do it. Okay. So if you want to prevent that, you can go to type 1 photoinitiator containing composites. So type 1 photoinitiator, they do not require any co-initiators. And also your camphor quinones, they will produce only one free radicals. But your type 1 photoinitiators, in fact, they produce two, three, four radicals. So such examples are your Lucerne, TPO, PPD. All those things are type 1 photoinitiators, which are available only in higher end composites like your Evo Ceram and ultra dent composite in your I think in Shofu there is one composite which has PPD in it. So these composites, Ivosirin TPO is actually, Lucerne TPO is actually patented by Ivoclar, and it is present only in higher end composites like your Impress and your Evoceram and those things only. So those composites are one syringe itself more than 5K. So only if you go for higher end composites, you will have type 1 photoinitiators, and this yellowish discoloration won't be there. Okay. So other than that, if you're using a normal composite, whatever is available economically, 2K, 3K, the composites which are available in the market, every composite is going to have camphorquinone, and camphorquinone will have amine also with it. So this amine will cause yellowish discoloration no matter what you're going to do. Okay, after 1 or 2 years, there is going to be yellowish discoloration, and that is the major disadvantage of composite restoration. Okay, so either you need to go for higher end composite like your Impress or something like that. If you're using that for composite veneers, you will be charging at least 10 or 15K per tooth for composite veneers itself, which is quite equal to ceramic veneers. Okay. So yeah, that's why patient choose ceramic veneers. So even either I go for lower end, if the patient is budget friendly, I go for composite veneers like 5K or 6K. Only if the patient is affordable, I don't go for any like a type 1 photo initiator containing composite material and all. I straight away go for veneers because it's quite equal to it budget wise. So I don't recommend any type 1 photo initiator materials. But when it comes to posterior restorations, you can always go for tetric evo ceram bulk fill, which is actually contains a type 1 photo initiator in it. You can go for posterior. Composite restoration color change over time. Yeah, covered. Should we use ethanol wetting procedure after using sterile cotton? So ethanol wet bonding, we are doing it for two purposes. One is to disinfect the cavity. Yes, if you're using sterile cotton, no need to do it. And the second thing is to enhance the bonding. Okay. So when you're going to use ethanol, it will replace the water in between the collagen fibers, and it will help your bonding agent to dissolve. So that is why we are using ethanol. Immediate dentin sealing. So what is immediate dentin sealing? So many people don't understand what is immediate dentin sealing. So whenever we are going to expose a dentin, okay, so I told you dentin is having a unconditional love for composite or any type of resin material. So immediate dentin sealing, we usually do it for ceramic veneers, your ceramic onlays, inlays, when we are going to bond the indirect restorations. It takes too much of time, okay, in between the bonding and for the restoration to come. Preparation and bonding, there is a gap. Okay, so only then we will be doing immediate dentin sealing. So immediate dentin sealing is a must. Whenever you have a exposed dentin surface, if you want bonding to be proper, immediately after cavity preparation or immediately after tooth preparation, you have to seal it with bonding agent. You can either use a generation 7 bonding agent, one coat, or you can even use a generation 5 bonding agent. You immediately put bonding agent and cure. That is the only thing. Okay, that is immediate dentin sealing, so that when the restoration your veneers or your inlay onlays come, you can follow the protocol of bonding and you can just bond it. Okay. Suggest good sectional matrix band. Sectional matrix, I think Garrison is the best. Okay. Garrison 3D XR or your Garrison Fusion matrix are best. Okay. So if you want an economical option, you can go for Palodent, Densplay Palodent V3. Or if you want much more economical option, you can even go for Torvium. Okay. So anything is fine, but more you spend, more flexible the matrix bands are, more smoother the matrix bands are, and more coverage it will give, more tight it is. So according to the cost, the quality will vary. But the best is going to be Garrison. I am using Garrison only. And not like I use Garrison for all the cases because it's quite expensive. So I am using Torvium also for normal cases. My junior doctors and all, they are using Torvium only. Okay. So either it's Garrison or you can go for Torvium. In between, if you want something quite economical, you can go for Palodent V3. RMGAC again, Dr. Ivoclar only, Cention. You get it in two. You get it like a syringe system also. You can directly dispense it, just like a flowable composite. Dispense it, cure it, and or you can you get it in a capsule form also. whichever is comfortable for you. Yeah. Good composite for anteriors, economical one, really good one. Yeah, doctor, a good composite for anterior, you can go for Brilliant Everglow. Okay, so Coltine Brilliant Everglow is very good composite for anterior. The material itself is a little bit shining, so whenever you're doing a composite veneers, it's going to be a very good material, especially for composite veneers. Okay, so it's actually Style Italiano recommended material also for composite veneers. So your Brilliant Everglow is going to be a very good material, strength wise and also aesthetic wise for anterior. That is the best and economical one also. So one syringe is only 1,600 something. Okay, it's not very expensive, 1,600 plus tax. So it should be within 2,000. So it's economical and very good also. I have been using it for many years. Oxygen inhibiting layer. Yeah. Doctor, I have already explained it. And then what happens if it use ethanol in between layering composite? No, doctor, you should never use ethanol in between the composites. The only thing what you will use in between the composite is your restorite, that is sculpting composite. Okay, your modeling resin. Modeling resin is the only thing which you will use over the composite, below the composite, in between the composite. Should the bonding agent agitate or not during the bonding agent application? So we should agitate, no? We have actually rubbed it on the tooth surface. So we should just rub it over the tooth surface. In case of class 2 filling, which matrix band and composite you suggest for gingival seat? So gingival marginal elevation, I will be using RMJIC, Cention, Flowable one. And then on top of it, I will be using a composite. Usually I go with bulk fill, Ivoclar extra fill, okay, to make it easier. But if I want strength not to be compromised, I usually go with Swiss Tech. Okay, so it's economical also. It's very very economical. Swiss Tech. It's quite good, decent for posterior composite. If you want very good strength and a premium material, you can go for extra fill, Voco extra fill and extra base. Yes, doctor. So usually many doctors, what they do is they will switch off the light when they are curing the composite. Okay, it's quite opposite. When you are carving the composite, you are supposed to switch off the light. And some of the lights, they have some filters nowadays. Okay, so you can buy that filter and put it in the light so that it doesn't cure. You can follow that because your lights will cure. Okay, will cure the composite. So always switch off the light while working with composite, or you can put a filter. Okay, you ask your chair technician, they will actually help you out with a filter. You can put it over the light. Whenever you're doing composite, you can switch on that filter. The one anterior aesthetic courses, they had suggested to use ethanol if all instruments get sticky or composite is sticky, can use it also while layering use. Never, doctor. Okay, Dr. Saukya BJ, you have asked, you have told that ethanol in between the instruments, over the instruments, in between the composite, it's never, 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 it's a blunder mistake. Okay, whoever suggested it, they have done a very big blunder mistake telling you that never use any other material. Even the modeling resin also should be used very not very generously. Okay, very little bit of modeling resin only to make it smoother. Okay, so only thing which you can use over the composite, in between the composite, everything is only modeling resin. You shouldn't use bonding agent, you shouldn't use ethanol. Ethanol is blunder mistake, and bonding agent also is a blunder mistake. Actually, if you use bonding agent over the composite, it will cause too much of yellowing. Ethanol, though, it will compromise the strength, bonding, and everything. Never use ethanol in between. One thing what you can do if your composite is sticky or your instrument is sticky, usually the premium materials like the LMArt instruments and your brilliant Everglow material. So even when I'm doing the hands-on, when I was doing the demonstration, sometimes it got stuck, right? It got sticky. So if you would have noticed very clearly, what I did was I was like beating it like this, right? So when you beat the material like this, it's going to get, it will not stick. Okay, so the premium materials, they will not stick. But when it comes to Valden composites and those, those composites, they will stick. So usually buy Brilliant Everglow or your Ivoclar, some good composites, and also LMAT instruments, instead of going for ethanol and these, these things are not acceptable. Okay. So you need to upgrade your composite and instruments so that it doesn't get stuck, instead of going for these things. These are all not acceptable, and they are not, there is no literature background for it. Okay. Bonding agent, first we apply this bonding agent and then we wash it for 10 seconds. We don't wash the bonding agent, doctor. Whenever we apply the universal bonding agent, we just spread it, air blow and spread it. Okay, air blow and spread it so that it gets evenly applied, and then we cure it. Okay. Deep cavity preparation, which burr is preferred? You can either go for a carbide burr or a diamond burr. So usually deep cavity preparation, I don't remove the caries. I just directly put MTA. Okay. I don't remove caries which is there in the top of the pulp. Okay. The recent vital pulp therapy techniques, if you go through, you will get to know how recently we are doing deep caries management. How much can we charge for a posterior composite restoration? Minimum 2K, doctor. So you have to charge at least 2000, but patient will not pay you because I'm having a different type of practices myself. So yeah, it's quite difficult. You can charge around 1000, nothing below 1000. Okay, so minimum charge 1000. If when you get more experienced, you can start charging 1500 or 2000. Always go for MTA. Okay, MTA you can go. You can go for MTA putty or anything like that. MTA biostructure safe endo is good. Okay, for deep caries management. Beautiful composite have not used, doctor. So I have not used any Shofu products so far. So the only thing what I use in Shofu is universal opaquer flowable composite and Gluma sensitizer, desensitizer. So Gluma desensitizer is you should not use it before the bonding agent, doctor. Why? Because your Gluma desensitizer is actually a little bit closer to your bonding agent. It's a varnish. Okay. So when you're going to use it before using a bonding agent, it will cover the dentin, no? Then it will not bond. The collagen fibers will not be open to accept the bonding agent. Then how the hybrid layer will form? So on top of the tooth, there shouldn't be anything. Okay. So there shouldn't be anything except water and alcohol in between the collagen fibers, so that your bonding agent can just infiltrate into the collagen fibers. So it's better not to apply any Gluma desensitizer before bonding agent. If you are following a proper bonding protocol, like how I told you, don't etch deeper dentin, self etch only on the deeper dentin closer to the pulp region, and selective etch only 5 to 10 seconds superficial dentin etching, and all those protocol if you are following, after doing bonding itself, the patient will not have any sensitivity. Okay, so there is no necessary for you to apply any Gluba desensitizer. Doctor, for anteriors, I use this Brilliant Everglow only. For all my anterior cases, I'm using Brilliant Everglow. And for posteriors, if I'm doing economically, like my junior doctors are doing, we use Swiss Tech. Okay, Swiss Tech we use. And in case if I'm doing the posterior, I use a Tetric Power Fill or Extra Voco, Extra Fill and Extra Base. Okay, so this is my usual materials which we buy in our clinic. So how long do we have to wash the etchant? 10 seconds, doctor, till the etchant completely gets removed. Etchant should get completely removed. So if you have to wash for 40 to 60 seconds for it to get completely removed, then you have to wash it. Okay, so that's the thing. So you make sure there is no blue color etchant anywhere around the cavity. So that is the only thing for washing. So may it be 60 seconds or 10 seconds. Any other doubts? Okay. So I think the doubts have been covered. So thank you all for giving me the time to teach, and it had been a very good session today. And we will just meet next month with another session. Thank you, doctors. Thank you. Thank you so much. Modeling resin, doctor has asked a last question. I will just answer that before going. Role of modeling resin. So modeling resin has no role. Okay. Modeling resin, without modeling resin also you can do a composite. Since you guys told me, you asked me like composite is sticking, ma'am. The instrument is sticking. So for those reasons, okay, to smoothen the composite, we are using modeling resin. Before, we were using bonding agent, alcohol, and many people told many things to use. Nothing, you need to use modeling resin. The purpose of modeling resin is to help you sculpt the composite without sticking. Okay. So you need to use it very minimum. That is also not advisable to use a lot. Okay. Don't use it more because it will compromise the strength. Just minimum on the superficial layer. Thank you, doctors. Thank you.